Torticollis. The sternocleidomastoid muscle takes origin from two tendons, one from the manubrium sterni and one from the medial third of the clavicle, that combine to form a single muscle bundle running in the neck superiorly and posteriorly to insert onto the ipsilateral mastoid process of the temporal bone. The function of this muscle is moving the head from side to side and up and down. Congenital torticollis refers to lateral neck flexion that causes the head to tilt to one side with neck rotation that causes the chin turn to the opposite side. It is a common complaint in children. Doctors do not know the exact cause of congenital torticollis, but it can run in families. Malposition of the head in utero has been proposed to contribute to its development. In general, torticollis is classified as either congenital, present at birth, or acquired, occurring later in infancy or childhood. By far the most common type is congenital torticollis. A wide variety of conditions can also cause torticollis due to cervical muscle spasm or cervical nerve irritation. Acquired torticollis onset at is greater than or equal to 6 months of age. It will be discussed separately later. Congenital torticollis is a musculoskeletal deformity caused by the abnormal contraction of the sternocleidomastoid muscle. Although children have this when they are born, parents may not notice it until children are 2 to 4 weeks old, as they start to gain more control of their head movement. In congenital torticollis, the head and ear are tilted toward the affected sternocleidomastoid muscle and the chin points to the opposite side, and the cervical range of motion is reduced. Inability of the examiner to passively rotate the chin past the shoulders and laterally flex the neck so that the ear touches the shoulder. A characteristic mass may be palpable in the inferior 1/3 of the affected muscle. The mass is well circumscribed and firm. The mass may be the first sign of congenital torticollis in an infant between 1 and 8 weeks of age. It usually resolves spontaneously by 2 to 6 months of age. The maintenance of a head position with face turned to one side, as occurs in children with congenital torticollis, can lead to positional deformation of the skull and facial asymmetry. The diagnosis of congenital torticollis usually can be made on the basis of history and physical examination. The doctor will also examine the child's hips and feet because there is a possibility that torticollis may be associated with developmental hip dysplasia and foot deformities. We do not routinely obtain imaging studies in young infants with congenital torticollis and characteristic clinical features, but it may be warranted to evaluate the possibility of bony abnormalities in selected clinical situations. Should also be considered in children who present after 6 months of age. Among infants with a sternocleidomastoid mass and atypical clinical features, for example, mass in superior rather than inferior muscle, mass not well circumscribed, sternocleidomastoid mass not firm, ultrasonography of the sternocleidomastoid may be helpful in confirming that the pseudotumor is muscular in origin. Once your doctor has determined that your child has congenital torticollis, parents and the child will begin a program of physical therapy designed to lengthen the shortened sternocleidomastoid muscle. Parents should be instructed to hold the infant so that he or she rotates the chin toward the shoulder of the affected side during feeding. For example, for the child with head, ear tilted to the right and chin rotated to the left, torticollis involving the right sternocleidomastoid, cradle the child in the left arm so the head is tilted to the left and the chin is rotated to the right while drinking a bottle. Parents should also be instructed about the importance of prone positioning, tummy time, when the infant is awake and being watched by an adult. Prone positioning with the head up stretches the sternocleidomastoid and strengthens the neck muscles. As a part of the home exercise program, the home environment can be adapted to encourage the infant to turn the head in the direction that stretches the sternocleidomastoid muscle. Examples include placing the infant in the crib or on the changing table so that he or she must rotate the chin toward the shoulder of the affected side to view the room. For example, for the infant with torticollis with head, ear tilt to the left and chin rotation to the right, place the infant in the crib supine with his or her right side closest to the wall. The infant must then rotate the chin to the left to view the room. Similarly, place toys or a mobile on the right side of a supine infant with torticollis with head, ear tilt to the right and chin rotated to the left. To view the objects in the right upper visual field, the infant must tilt his head toward the unaffected side, thus improving the head tilt component, and rotate the chin to the affected side, improving the chin rotation component. Passive stretching is performed to elongate the shortened sternocleidomastoid muscle. To address the rotational component of the torticollis, with the infant in the supine or sitting position, the caregiver should place one hand on the shoulder of the unaffected side, that is the side toward which the chin is rotated. The other hand should gently rotate the infant's chin so that the chin touches the tip of the shoulder of the affected side. For example, for the child with torticollis with the head, ear tilted to the right and chin rotated to the left, stabilize the left shoulder and rotate the chin toward the right. To address the head tilt component of the torticollis, the caregiver should place one hand on the shoulder of the affected side, that is the side to which the head is tilted. The other hand should tilt the head away from the side of the shortened muscle until the child's ear touches the shoulder of the unaffected side. For example, for the child with torticollis with head, ear tilted to the right, stabilize the right shoulder and tilt the head and ear to the left shoulder. For the exercises to be effective, the infant must be relaxed and providing no resistance. The exercise should be stopped if the infant resists. These exercises be performed in sets of 4 to 5 repetitions, each held for approximately 1 to 2 minutes. Parents may be encouraged to identify a regular time to perform the exercises, such as every time they change a diaper. Cervical spine abnormalities are the primary contraindication to stretching exercises. Anterior, posterior and lateral radiographs of the cervical spine may be warranted before the exercises are recommended. We refer infants to outpatient physical therapy if the home regimen is not successful after 4 to 6 weeks. The physical therapist may recommend using a simple device called a tubular orthosis for torticollis, TOT collar, which is really just a small piece of plastic tubing that fits around your baby's neck. The TOT collar is designed to help babies straighten their heads and strengthen their neck muscles. Your physical therapist will teach parents the proper way to use a TOT collar. Children who have torticollis with asymmetry of the face and head usually respond very well to non-surgical interventions using customized, corrective helmets and molding cups. Infants should be evaluated at 2 to 4 week intervals. Successful therapy results in midline head position and full range of motion of the neck. The majority of cases of congenital torticollis resolve after 4 to 5 months of first-line interventions. We suggest referral to surgery for children with congenital torticollis who failed to respond to at least 1 year of stretching.